prolactinoma treatment. We have to give dopamine agonist, which is going to work on the dopamine receptor in the pituitary, and that's going to shut off the prolactinoma. Failure of the thyroid migration that can lead to thyroid can reside anywhere along the thyroglossal duct path, which is it can be lingual, sublingual, prelaryngeal, or at the normal location. Then we have the metformin, which increases glucose uptake, decreases gluconeogenesis, and unchained endogenous insulin production. Uh, Insulin, how is it formed? Insulin comes in from the nucleus. The mRNA from the nucleus. Insulin mRNA goes to the RER, where it is called pre-proinsulin. That forms the that gets into converted into proinsulin, which goes to the Golgi apparatus, and which then gets packed into the secretory granules, and that secretory granules contain endopeptidases, and those endopeptidases within the secretory granules, they break down proinsulin into insulin and C-peptide, and when it's and then they release the insulin and the C-peptide. So endogenous is always insulin and C-peptide that gets released with insulin. Uh, External branch of superior laryngeal nerve innervates only cricothyroid muscle. It runs close to superior thyroid artery and vein. When you're doing like superior lobe, dissection of the thyroid in the superior lobes, you had three things together with it: superior laryngeal nerve, superior laryngeal artery, and vein. So there is a highly chance that you can cut them through if you're not experienced enough. So it can lead to cricothyroid muscle damage, and that can lead to not the voice loss, but like if you're a high performer, you can get some pitch loss in the voice. Okay, syringomyelin forms ceramide, and the enzyme that they need is a syringomyelinase. If defective, if deficient of syringomyelinase, it leads to Niemann-Pick disease. What Niemann-Pick disease is? You have a child with the cherry red spots of the macula, which are called the retinal opacities, and hepatosplenomegaly and foam cells. Why foam cells? Because those foam cells contain syringomyelin in it. Okay, that's the Niemann-Pick disease. The enzyme deficient here is syringomyelin. You have decreased ACTH, leads to decreased cortisol, leads to decreased phenylethanolamine and methyltransferase, uh, decreases epinephrine formation. This is the enzyme that converts the cortisol into the epinephrine. So, uh, actually, norepinephrine to the epinephrine. So, when you don't have this enzyme, you're not gonna have epinephrine no matter what. So, who's actually regulating it is the cortisol itself. It's cortisol itself. So when you increase cortisol, you got increased epinephrine. You have decreased cortisol, you have decreased epinephrine release. Uh, then you have the next is the congenital adrenal hyperplasia. Is the most common cause is 21 hydroxylase deficiency. Uh, Most common is 21 hydroxylase deficiency. So you have a uh, decreased cortisol, decrease granulosa fasciculata, but only increase reticularis, which is the last layer. So that's going to give you a lot of testosterone, and increase in hydroxyprogesterone, and decreased cortisol will lead to ACH to be released a lot, which leads to adrenal cortical hyperplasia. Treatment of this is low dose corticosteroid to suppress ACTH. Low dose corticosteroid to suppress ACTH. Next is glucanoma. Glucanoma is the glucanoma is dermatitis and diabetes mellitus, right? So in glucanoma, of course, you can have hyperglycemia because glucagon is there, but on top of that, you will have dermatitis, which is a neurolytic migratory erythema. The next we have in DKA, we administer the IV regular insulin in hospitals, and after the patient discharges, we give them insulin subcutaneous. Subcutaneous. So why? We always administer uh, two things: subcutaneous regular insulin for the postprandial hyperglycemia, and it's always given with the basal insulin for fasting hyperglycemia or euglycemia. Uh, so the basal one, the basal, and you have for the basal insulin, we can give NPH or glargine, and for the normal, that's a regular insulin. So regular insulin is administered pre-meal. Basal insulin is administered one dose every day. Rapid acting insulin mimics rapid acting insulin mimics the postprandial physiological insulin secretion. Regular and NPH are recombinant human insulin without any structural modifications. Next is increase in calcium leads to inhibition of the smooth muscle depolarization, which leads to decrease in intestinal contractility, which leads to constipation. The next is the major trauma or sepsis or hemorrhage leads to stress hyperglycemia by secretion of the catabolic hormones, increase hepatic glucose production, cortisol, catecholamine, glucagon, via gluconeogenesis and glycogenolysis. So when you have a major sepsis or hemorrhage or trauma, it leads to stress hyperglycemia by secretion of catabolic hormones, which leads to increased hepatic glucose production, gluconeogenesis, and glycogenolysis and breakdown of glycogen that's already there. What are the catabolic hormones? That's cortisol and catecholamines like epinephrine, norepinephrine, and glucagon. Next is octreotide. Octreotide inhibits the growth hormone release. Octreotide leads to growth hormone release. Octreotide leads to inhibition of the growth hormone release. It leads to uh, decrease in IGF-1, insulin-like growth factor 1, and decreases the adenoma size in acromegaly because you're inhibiting the growth hormone. The next you have the anastrozole. Anastrozole inhibits the aromatization in adrenal cortex, decreases androgens like estrogen or estradiol. That's anastrozole aromatization inhibition. The next is oral glucose is to increase insulin glucose levels by stimulating the incretins. Uh, and it increases insulin. Oral glucose leads to increase insulin level faster than the IV glucose because the oral actually right away stimulates the incretins, which is the GLP-1 and GIP, which then lead to secretion of the insulin. But the IV has to go to the pancreas to stimulate the insulin, so that's a little slower. So in hypoglycemia, a candy is always better than giving IV glucose. The next we have a metformin. Check for serum creatinine levels before starting this therapy. Serum creatinine, that's the renal test. Serum creatinine level before starting the therapy. The next increased ACTH. If you have increased ACTH, the first layer, the granulosa, will be normal because it is not regulated by ACTH. It is regulated by angiotensin 2 because the granulosa secretes aldosterone. So this is gonna be normal, but The other layers, like the fasciculata and reticularis, they gonna go into hyperplasia, and fasciculata secretes cortisol, so it's gonna form the Cushing sign symptom. Reticularis secretes the steroids, so it's gonna lead to in females can lead to irregular menses and hirsutism. In males, it's gonna cause secondary sexual characteristics, deepening of voice, and all that. Uh, pay